Good afternoon, everyone. And today I would speak on CGMS in optimizing type 2 diabetes, how we should shift from a static HbA1c model to a dynamic continuous glucose monitoring, even in type 2 diabetes. So, this will be the overview of my talk. I'll go through the next slide. So, why is it important in type 2 diabetes? We have mounting evidence that type 1 diabetes and CGMS go well, but in type 2 diabetes, even on OHS, should we use CGM? Yes, because we are not just dealing with diabetes as a disease, we are dealing with a global health crisis because we have lesser life expectancy of almost 20 years. We have multiple comorbidities, and it's a major economic burden. Especially in India, the situation is much more critical. We have 101 million diabetics currently, and 57% are still undiagnosed. And the situation is also different in India. We have earlier onset in younger age groups. High glycemic variability is especially seen in as well. And most often, even with all the technological advances, even everyone has a cell phone, but most of the type 2 diabetes patients still have HbA1c above 8, at least more than 50%. And we also are at increased risk of cardiovascular outcomes. There is also a pathophysiological rationale for use of CGM in type 2 diabetes because it's very progressive dynamic disease, and there is a progressive decline of beta cell function at almost 4 to 5% each year, and there is also loss of first phase insulin as the diabetes and decreased incretin response, thereby also on top of insulin resistance. We have more of postprandial hyperglycemia or carbohydrate loaded diets, especially in South Asia. And there may be differences in oscillatory insulin, so there can be non-phenolic glycemic variability, exercise response variability, which cannot be detected using HbA1c or SMBG. And glycemic variability is now recognized as an important CV risk factor, which increases the endothelial oxidative stress and the endothelial dysfunction as well. But if we look at this data, the HbA1c is 7, which we usually see in our clinical scenarios, and we think that it's normal, so we can continue the same medication, or maybe if it's an younger population who wants remission, we might have to increase it a little. But the same profile is different across different patients. The glucotypes are different. So patient A is at high 100% target, but patient B and C, they are at increased risk of comorbidities even when the HbA1c is 7. So this is not a reliable source of glucose history, but it's just an average. So time in range provides more actionable information than A1c alone, and this should also be implemented in type 2 diabetes. Especially in India, we do have a higher rate of iron deficiency, which will falsely increase the HbA1c up to 0.3 to 1%. And we also have the ethnic glycation variations and postprandial dissociation as well. And coming to the self monitoring of blood glucose limitations, also, we do see a behavioral bias in our patients. Patients tend to know when their glucose levels are normal, and they tend to give those data points to us. So we are misguided by even the behavioral bias. So there is more risk of comorbidities even at a lesser HbA. So this is the time for precision medicine, personalized diabetes management. So we should move on from the population-based guidelines to individualized glucose patterns. We have to collect the data sets from there, and we have to be able to tailor the interventions based on their clinical profile, their dietary patterns, their exercise patterns, and their lifestyle as well. And CGMS enables us by revealing all the metabolic responses to diet, exercise, medications, and stress. Uh, a quick overview of the CGMS. We do have real-time CGM and intermittent, that is a flash glucose monitoring. In India, we do use most of the flash glucose monitoring, but now Libre have come up with Libre 2 Plus and 3 Plus, which are also the real-time CGM. The key metrics that we should be seeing when we see a CGMS report is, first important is not the time in range, but the time below range. It should be less than 70 mg per deciliter, should be less than 4%, and less than 54 should be less than 1%. This is very critical because it detects a level 1 and level 2 hypoglycemia. And this should be the first parameter when you check in when the patient comes with the CGMS report, because this causes increased CV events, mortality. And if you have to decrease your decrease your diabetic intervention. That should be the goal first. And then the second important metric is the time in range. It should be 70 to 180, above 70%, and it correlates with an average HbA1c of 7%. Each 10% time in range also decreases the HbA1c by 0.5%. And the other metrics are time above range, which should be less than 25%, more than 180, more than 250 glucose should be less than 5%. This also guides therapy intensification. And the other critical metric is also the coefficient of variation, which determines the glucose stability or the instability. So CV more than 36 indicates glycemic instability, and it requires intervention regardless of what the HbA1c is. Even at a HbA1c of 7 or 6.5, if the CV is more than 36%, you have to intervene there, either be it modifying the diet or exercise or sleep, but some intervention has to be done. And next, coming to the glucose management indicator, which is the estimated HbA1c from the data of 10 to 14 days. It correlates more or less with HbA1c with plus or minus 0.5%. But if the difference between GMI and HbA1c is more than 0.5%, then you have to look into if there are any confounding factors for HbA1c, because RBC lifespan does not affect glucose management indicator as it affects HbA1c. So we have mounting evidence also coming, and we already know in type 1 diabetics, increased time in range is less likely to experience complications. Even in type 2 diabetes, patients who spend more of time in range are more likely to experience a lower rate of MACE. So as you can see here, as the time in range increases, the prevalence of at least one microvascular complication comes down in both type 1 and type 2. And specifically coming to type 2 diabetes, we also have several meta-analysis showing HbA1c reduction of, they have compared real time as well as flash. Obviously real time, because it gives the trends and the alerts, it has more of HbA1c reduction than the flash glucose monitoring. But when compared to SMBG, both are clinically significant. And also the time in range is significantly increased with CGM and better glycemic control. And additional findings are decrease in time above range and decrease in the time below range, and the decrease in glycemic variability as well. And especially this is for basal insulin users. This study has been done with patients on basal insulin. HbA1c also has decreased by 0.4% additional to the SMBG. There is also time in range increase about 15%, which is very significant clinically as well. Time above range and below range reaches significantly. One point we have to note down in this study is that they have not increased their insulin dosage. Just with the dietary modifications, behavioral modifications alone, they have achieved this significant result. So if you tell a patient to follow the behavioral modifications, which we have been doing since long, but they do not comply to that, but if they see the real data, they are able to comply to the behavioral modifications, and this effect seems to be sustained for a longer period, up to 6 months to 1 year. And then we have the diamond study, where patients on multiple daily injections were also randomized, and even at that patient group, there is a mean difference of 0.3% excess HbA1c reduction in patients on CGM. Even without any insulin dosage, they have no increase in hypoglycemia and improved glycemic control. This immediate study is done in non-insulin users, only type 2 diabetes on OHES. Still, there is significant reduction of HbA1c of 0.3% with CGM, and time in range improved by 9.9%. That translates to almost 2.5 hours per day. This study also again highlighted the importance of not just CGM. We cannot just put on CGM and tell him to come back after 14 days, because the data will be overwhelming for him. He does not know what to do when the trend arrow goes up or down or it's stable. So we have to give some form of structured education on CGM pattern interpretation to the patients as well. Have to take that time of 5 to 10 minutes. We have to reiterate the importance of behavioral modifications, and when the patient logs the food and sees the patterns coming down for himself, then that is when he will comply with the behavioral modifications. So this study has highlighted the importance of structured education for the patients on CGM pattern interpretation. And this study was done for lifestyle modification in diabetics with HbA1c of 7 to 12%, not on insulin or sulfonylureas. They have given CGM alone versus CGM plus a food logging app, there is significant difference from just giving the CGM and providing the structured program and a food logging app. The time above range have come down from 55 to 21% when there is an additional food logging app given. Time in range also have improved tremendously from 46 to 72%, which is a staggering number. And HbA1c also has decreased by 1.3%. There is also weight loss at the end of 6 months. 7 pounds weight loss have been seen in the CGM plus food logging app. Both groups have shown significant improvements, but when they have the data of food, what they eat, and the difference they have seen on the CGM metrics, there is a significant difference. So we need not do all of it on our own. Now there is AI integration with CGM technology. They are predicting algorithms, forecasting glucose trends 30 to 60 minutes prior, and they are giving hypoglycemia alerts before the excursions even occur. This prevents glucose emergencies in majority of the population. Now we also are using AI to recognize the patterns, identify the meal responses, detect the dawn phenomena, exercise patterns, and they're individualizing and they're giving personal insights. For example, if the patient's trend is going down, they'll ask the patient to eat a snack, or if it's going slightly higher, they ask the patient to take a walk for 10 minutes or so. So this AI integration also will help us as a physician to help in decision making, how to automate insulin dosing, meal bolus recommendations, and exercise adjustments. So this has a deep learning model and an machine learning algorithms have also been integrated. So from that technology, there have come a digital twin technology in diabetes management. So what are digital twins? They are the virtual replica of individual patients' metabolic system they have created using AI and CGM. So this is broadly how a digital twin construction has taken place. They have the physical patient wearing the CGMs for at least 3 months, and then they'll have the genomic data, their EHR, health app data, social data, and they have the ontology department doing all of these things. And they have created a digital patient. From there, we can have personalized blood glucose regulations throughout the year. They can have glucose prediction even when the CGMS is not in place. And there is need there this provides the personalized lifestyle recommendation which the patient requires. So we know CGM is really effective in type 2, but when to use? The high priority should be given for any patient who is having frequent hypoglycemia, especially in unawareness patients, especially elderly who are living alone, and patients who have high glycemic variability, suboptimal control more than 8%. Patients who are planning pregnancy or on GDM, we have to give them high priority to start CGM, and moderate priority can be given for treatment intensification, patients who are starting insulin therapy or require lifestyle modification support. But ADA endorses all patients, young or old, who have been diagnosed with type 1 or type 2 can start with CGM at the onset, and who are on insulin, they can use CGM daily. Intermittent CGM also they have been tested, and at least 1 week at baseline and repeated 3 months, or quarterly 1 week sessions also have seen decrease in the HbA1c, and that decrease is also sustained over 6 to 12 months. So this can be a cost effective strategy when we are used in India. So there is also a expert recommendation on how frequent the CGM should be used. As we have discussed, continuously use can be recommended in type 1 or type 2 patients on intensive insulin therapy or high GV or hypoglycemia risk, and pregnant patients there can be continuous use. All the other patients can use intermittently, all based on the treatment regimen and individual risk. But as we have discussed, if the patient is having acute complications, or patient has gone on steroids, or patient has undergone kidney transplantation or any transplant having immunosuppression, then CGM can be used frequently. But we also need to individualize glycemic control goals even in CGM metrics. So we know the metrics for type 2 diabetes, but for older population and high risk with complications in type 2 diabetes, there can time in range can be more than 50%, not 70%, as we see in normal individuals with type 2. But the most preference should be given to time below range. Less than 70 should be avoided at all costs. It should be less than 1% to as minimum as possible. Time above range more than 180 should be less than 50%, and more than 250 should be less than 10%. And we also have the real world evidence coming in. There is also not just about glycemic control, there is also reduction in hospital admissions for acute diabetes events after CGM is initiated in type 2 diabetics. And the benefits is again sustained for at least 1 to 2 years. This is one interesting study which have used CGM used along with one self evaluation of unhealthy foods algorithm. Uh, so based on the data and personalized data interventions, they have stayed on healthy foods with low postprandial glucose at the end of the study. And long term benefits are still there. Even after stopping CGM, the long term benefits are still durable at the end of 12 months. Not just in type 2 diabetes, CGM also has a role in preventing pre-diabetes progression. Also, we have data coming in that. And this is the last slide. So the next coming up frontier is time in tight range, which is not just TIR, but even structure criteria. It should be 70 to 140. This is not applicable for everyone, but for those who are already having TIR above 70 and whose HbA1c is 6.5, if they want to achieve remission, this should be the next target. So TITR is glucose from 70 to 140. It should be, for diabetes remission, it should be more than 90%. Yes. So the key takeaways would be, don't worry, you can use CGM in type 2 diabetes even without insulin on OHAs. If the patients are active, they want to go into diabetes remission, then you have to use CGM at the onset of type 2 diabetes. Even in healthy patients who are at the range of pre-diabetes, we have several glucotypes coming up. So even in such cases, there are predictive algorithms to identify which high risk patients can go into pre-diabetes or diabetes in the next 5 years. So prioritize CGM for frequent hypoglycemia, high glycemic variability, pregnancy, and those who are on insulin, but all the others you can take a call.